Well, we'll move back to the general session. So I'd like to welcome the allied health professionals back into the combined physicians allied professionals session. And as you're kind of seeing throughout all these talks, this is really a team sport, that taking care of patients with inherited arrhythmias requires all of us to come together around the patient, around the family. And with that in mind, I'd like to introduce the next talk on in establishing an inherited arrhythmia program. I'd like to introduce Dr. Stephanie Chandler. Dr. Chandler went to Case Western Reserve University Medical School. She did her residency and general pediatric cardiology fellowship at Boston Children's. She then did an EP fellowship at Boston Children's, and then she even did an inherited heart disease fellowship at Boston Children's. Since then, she has moved to Lurie Children's in Chicago and has Northwestern University, and has started up an inherited arrhythmia program. So with that, I'd like to introduce Dr. Stephanie Chandler.
Let's make sure that you guys can all see my slides. Can you all see that? Okay, great. First of all, thank you so much for having me. I have no disclosures to report. I've been asked to give a talk today on establishing an inherited arrhythmia program. To be quite honest, my first response when I saw the title was, I'm pretty much the wrong person to be giving this talk. All joking aside, my goal today isn't to pretend to offer the perspective nor feign the experience of other senior experts in the field, many of which we've just heard from. My goal is to offer the perspective of someone who's pretty green, who, much to the shock and chagrin of most people I know, decided after 7 years of medical training that a year of training dedicated to inherited arrhythmias would be very valuable. And finally, as someone who has been struck by fairly exquisite luck, both in my training and in my early attending life, by the chance to work alongside and learn from some of the incredible mentors in this field. So with that caveat, and given the short nature of the program, I'll focus on two main objectives. What do I think is the value of an inherited arrhythmia program? And what are some of the critical components of an inherited arrhythmia program? Inherited arrhythmia programs fall under a greater umbrella of cardiovascular genetics, along with a number of other disorders and syndromes, inherited arrhythmias, including long QT, CPVT, and unexplained sudden death, all under the recommendation of the American Heart Association, the American College of Cardiology, and the Heart Rhythm Society qualify for referral to a cardiovascular genetics program. When we consider specialist centers or inherited arrhythmia programs, the first logical question in my mind to ask is, why are they special? In the entire field of medicine, and particularly, for example, within cardiology, we have specialists within specialists. This is a growing theme in our field, and as both the breadth and depth of knowledge expands, we search for people who are sub-specialized. To that end, patients and families don't just want to see a provider who sees some patients with long QT. You want to see a provider whose practice is deeply dedicated to the care of patients with long QT and other forms of arrhythmia. So providers within an inherited arrhythmia program offer expertise and experience in the tasks listed here. Things like detailed phenotyping or understanding the physical manifestations of disease, genetic testing, risk stratification. As an example, why aren't all patients with long QT syndrome the same? And finally, in the screening and education of patients and their families. Funnily enough, it's not just those of us who work within these programs who think that these programs and having dedicated providers within these programs are important. In fact, these recommendations have been outlined in more than one scientific statement over the past 5 years by the American Heart Association. Not only is cardiovascular genetics a rapidly evolving subspecialty, as you've heard through many of the talks today, but we as practitioners are being charged, not unfairly, with trying to keep up with this burgeoning knowledge. And out of this comes an increased need for programs dedicated to the care of these patients specifically and their families. But how do you know that I'm not just blowing smoke? For years within the field of interventional EP, for example, we've known that having experienced and well-trained operators in the EP lab is associated with better outcomes and fewer complications. And we think that's also true in the care of patients with inherited heart disease. Sure enough, in a retrospective analysis published in 2016 out of a major center in Ontario, Adler and colleagues found that comprehensive genetic and clinical management in a specialized inherited arrhythmia clinic was associated with low mortality and low cardiac event rates. And this is just one example. I'll offer one personal example to highlight my fundamental belief that these programs provide expertise. One of the challenges facing providers in the wake of increased availability and usage of genetic testing is interpretation of those results, and specifically counseling families with pathogenic variants, but no phenotypic evidence of disease, AKA, I inherited the gene for hypertrophic cardiomyopathy, but my cardiac ultrasound is normal right now. How do we adjudicate this for families? In approximately my 4th month as an attending, a 9-year-old male was referred to me for a pathogenic variant in SCN5A, which was discovered as a secondary finding on his genetic testing, given a history of developmental delay, ADHD, and autism. His corrected QT at the time interval at the time was about 430 milliseconds, and there was no concerning family history. This is his high lead EKG, which is not perfectly normal, but didn't have some of the classic things that we look for when we think about Brugada. But as I sat down to look and review this case with my cardiovascular team here, we discussed the importance of anticipatory guidance for this family. When I finally met with this family and this child in clinic, his mother, being a nurse, came to clinic armed with very thoughtful and very poignant questions about literally all of the conditions shown here that she had come across during her reading. Sure enough, about 3 months later, this 9-year-old patient showed up in an outside ER with a fever of 104 in the setting of influenza and this EKG, a rather striking Brugada pattern that prompted transfer to our inpatient service for monitoring for the duration of his acute illness. And fortunately, he did well without any ventricular arrhythmias. But interestingly, his mother, who carries the same pathogenic variant as her son and affected with the same flu and a fever as her son, had an EKG performed at the same time, which was unchanged from her normal baseline ECG. I'm not sure that I, as a fresh attending, even with advanced training, might have been able to be so definitive in my recommendations to this family when I first met with them in clinic. But having discussed this case within our team, I, and therefore the family, had the benefit of multiple providers whose practice is dedicated to families just like this one. And this case, at least for me and my own practice, serves to highlight the next point, that one of the inherent benefits of these programs is that they often, you get more than one person, you get a whole team. As we move into the discussion of not just why we should establish these inherited arrhythmia programs, but delve further into the details, it's important to say outright that much like everything in medicine, there is no one way to do this. There's no magic recipe for building an inherited arrhythmia program. In both teams with which I've worked, the model looks like this on paper. As opposed to the more somewhat antiquated traditional hierarchy in medicine with an attending physician or surgeon at the top and a series of subordinate residents, fellows, and staff below, this model instead revolves around the idea of patient-centered care, with each team member having an important role in the care of the patient and the family. For me, the value of these teams can't be underscored enough, specifically as it has pertained to my own education. The number of things I've learned over the years, not just from other MDs with more experience than myself, but from our genetic counselors educating me about testing and life insurance, from a child psychologist imparting to me the wisdom of not lying to a child, even when we think that keeping the truth from them is the kinder thing to do, and from program coordinators who so often give us insight into these families before they even walk in the door for their clinical visit. Each member of these teams has an important role to play. And these teams perform optimally under the guiding force of thoughtful and experienced leaders whose focus both on the health of their patients and the health of their teams is paramount. Both of these two familiar faces will be quite mortified that I included this slide, but nevertheless, it underscores a hugely important point in my mind. My very wise mother used to tell me, people don't always remember what you say, but they'll always remember how you made them feel. And I think this doesn't just apply to our patients, this applies to our working care teams as well. When building a team like that of an inherited arrhythmia program, it's critical in my mind that these teams are led by those people who bring out the best in every member of their team, know their team members as individuals, and finally, whose actions and behaviors set the tone. They set the culture for the entire group. This conference is full of senior mentors just like these two. But for me personally, both as a trainee and as a junior attending, these are the individuals who lead by example and whose care, compassion, and expertise is transmitted both in the care of their patients and in the leadership of their teams. Finally, you can't discuss leadership without discussing culture. Culture is inextricably linked to an organization's performance and success. It varies across organizations, across industry, and across geography. So what works for us in Chicago may be different than what works for the group in Atlanta. A successful culture within one organization or at one time may not translate to others. And as such, I think it's important to understand that when building an inherited arrhythmia program, that one size doesn't fit all. I'm certainly not going to tell you there's a blueprint for building a successful program because we're still building ours. With that being said, I do think that one of the similarities across all successful inherited arrhythmia programs is the presence of strong and thoughtful leaders who cultivate a team of hardworking and curious members whose collective focus is on the delivery of excellent patient care and fundamentally a group of people who both really enjoy the work and really enjoy working together. Lastly, I'll leave you with two final thoughts. Some groups have probably already mastered this, but one of the challenges that we have faced in our own team is the development of a family-centered visit, one in which both pediatric patients and their parents might be able to be evaluated. I don't think I need to underscore the importance of family-based screening to this group, but I do think finding ways to expedite and ease the screening process is critical for all of our programs. In closing, a rapid fire review. What's the value of an inherited arrhythmia program? Expertise, experience, and a team of providers focused on the care of patients with inherited heart disease. And what are some of the critical components when building these programs? There's no magic recipe, but good leadership and a focus on culture have time and time again proven to me to be of utmost importance. These are just some of my acknowledgements, and thank you for the opportunity.
Awesome. Well, thank you, Stephanie. And again, that really underscores the fact that this is it's a team sport. It takes a lot of people to really provide great care. With that in mind, actually, one of the questions that was asked on the app was, who are the key members of an inherited arrhythmia clinic? Question: genetic counselor, NP, PA, geneticists, bench researchers, psychology, etc.
Yeah, I think in every team, as I said, there's a slightly different and varied makeup. I think a genetic counselor is integral to all good programs. And I've been lucky to work with two exceptional ones in my career. But I think each team uses the resources that they have at their disposal and uses the team's sort of in the best way they can to provide the care that they can. Not everyone is going to be able to provide the same depth of care, have a psychologist, have great bench research. But that's one of the benefits of having programs like this, where you have a community of colleagues who can discuss cases, who can discuss these things when they come up, so that you're not ever really operating as an isolated group, but in fact, you're operating a little bit as a community.
Awesome. And I think we might have time for one more question. And this was, where does the general cardiologist or referring cardiologist fit in the care of inherited arrhythmias?
That's a great question. I think the best thing that we can say is they're an integral part, because they're probably one of the first people that see some of these patients walking through the door. And I think the relationships that you establish both in your own institutions and with outside and referring cardiologists is super important. So I think what I would say is, if you ever have a question or a concern and we can provide some expertise or even just have a conversation with you, pick up the phone and give us a call. That's how, all of us hope to operate, I think, always. And I think it provides the idea and the substrate for sort of the best care for patients going forward. They're sort of the door for us.
Excellent. Yeah, thank you very much. All right, well, we're going to move into the final session, which is a panel discussion. It's on the future of inherited arrhythmias. And so if attendees can switch into the WAHOBA app, and then the faculty are actually will be popping up in that talk in a second here.